Hello guys, welcome back to part 3 of Psychiatry. Today we're going to discuss about the psychotic symptoms, okay? I hope you guys remember from part 1 where we started from the basic mental illness and we subdivided it into various different variations where we spoke about symptoms. Under symptoms, we had discussed about neurotic and psychotic, okay? And I hope you guys remember this mnemonic that is JIPR, which is judgment, personality, insight, and reality contact, right? So I hope you guys remember this, and I hope you remember the very important point that in psychotic patients, all of these are either lost or they're reduced. They are either lost or they're reduced. And what is the most important symptom, guys, that is lost, okay? That is that psychotic patients have a loss of insight, okay? And what was insight? Insight is a self-awareness. Self-awareness as in that yes, that there is something wrong with me. I am having an issue. I need it to be solved. That is what I mean by insight. Insight meaning self-awareness. Okay. So we have already discussed all those in a better version in our part 1. So now guys, let us continue with the different psychotic symptoms. Okay. Of which the very two important symptoms are going to be delusion and hallucination, right? In the previous video, we spoke about delusion and ideas. Both of them had the same abbreviation, that was FFB, okay? But the only differentiating part was the second F, that is delusion, guys, is false fixed belief. False fixed belief, okay guys, this is very important. That is delusion. That means no matter the amount of time you explain this patient, no matter how good the doctor is, no matter how many degrees he has, if he will say that okay, nothing is wrong with you, but if this patient is so adamant that no, something is wrong with me, no matter what you do, he's never going to be convinced about it, okay? So that is what we mean by delusion, right? Next is hallucination, guys. What does hallucination means? It means that there's a perception without, very important, this is without a stimulus, right? There is a perception without a stimuli. That is what we mean by hallucination. Okay, guys? Next, the other symptom is going to be catatonia. Okay, the other symptom is going to be catatonia. And what do I mean by catatonia? It is the inability to move properly. Okay, we're going to discuss this in a much better way in our further videos. Okay. And what are the other symptoms, guys? Disorganized behavior. This patient is going to have a very disorganized behavior. I'm very sure you guys might have seen on road that there are these certain people that they would be roaming very shabby, wearing, they would be talking, aimlessly walking, wandering around, right? Talking, muttering, smiling to the self. These all are symptoms of psychotic patients, right? I'm 100% sure you guys might have definitely seen somewhere on the roads of India, different people just walking around, wandering around, aimlessly talking, okay, like aimlessly walking, sorry, talking to themselves, saying something, like whispering to oneself, okay? These all are psychotic symptoms, okay guys? So disorganized behavior, talking, muttering, smiling to self, aimlessly walking, wandering around. And I hope you guys also remember formal thoughts, right? What was formal thoughts, guys? That is a loss of association of your thoughts, okay? It is a loss of association of your thoughts. We have discussed this in a much better way in our previous video as well, okay? So now guys, our psychosis is divided into two, okay? One is a primary psychosis and the other one is a secondary psychosis, okay? Now what happens in primary psychosis, guys, that the symptoms, okay, if this patient is having a linear pattern, okay, this patient is okay, he's fine, all of a sudden, guys, this patient will come with psychotic symptom. There was a patient, he's fine, he's doing okay in his daily life, but all of a sudden this patient presents with psychotic symptoms, okay? All of a sudden the symptoms they start showing. Like this patient will have delusion, okay? In schizophrenic patients, what is the most common type of hallucination, guys? Auditory hallucination, right? I hope you guys remember that. Okay, so that is what I mean by primary psychosis. Whereas what happens in secondary psychosis, guys? In secondary psychosis, which we also call as mode congruent. What do we call it as? Mode congruent. Why mode congruent? Because, guys, this patient would have had a history of depression, okay? That this patient would be very low, okay? This patient would have a history of depression. All of a sudden, this patient starts presenting with psychotic symptoms. So, congruent means like two things that are joined together, right? So, that is what I mean by mode congruent, okay? That this patient came with who was depressive, all of a sudden starts showing me psychotic symptoms, okay? Now, for an example, what do I mean by mode congruency? Now, I told you that depressive patients, right, they are they're very low and all, right, we discussed earlier. This patient will then come with auditory hallucination, as in there will be a voice telling him, jump, commit suicide, right? Already you very well know depressive patients are always in a very low mood, okay? They have a very high chance of suicidal tendency as well, right? So then along with all those feelings, you start having auditory hallucinations, and that voice would be telling you, jump, go commit suicide, your life is meaningless, right? So that would be your auditory hallucination. Okay guys, another example that I could give you is mania patients, guys. You already know mania patients, we discussed in our early video. They have flight of ideas, right? They are very energetic for some reason, and along with that, if I mix auditory hallucination, they'll be like, you're the king, you can do whatever you want to do, you're the king, right? So these are the two examples, okay, that I can give you mood congruent. Okay, next guys, I hope you guys remember this. We also discussed this. Where do I see visual hallucinations, guys? Visual hallucinations will be seen in neurocognitive disorders, which we also call as organic disorders, right? Whereas auditory hallucinations, very important, schizophrenic patient. Tactile hallucination, or we call that as a cocaine bug. Where will I see that? In cocaine patients. Okay. Next guys, now let us understand the psychotic disorders a little bit better. Okay, let us now differentiate it on the basis of the timing. Okay, now what happened is, guys, that see, I hope you guys remember that we earlier discussed about DSM-5 and also about ICD-11, right? These are the two basic things that we see when we diagnose, right? That they are like ICD-11, I told you that it is accepted whole worldwide, whereas DSM-5 is mostly to the US, right? So now guys, ICD-11 and DSM-5 have differentiated psychotic disorders on the basis of their duration. Now guys, if any patient presenting with psychotic symptoms for at least 1 month, kitna 1 month, I will call that as a brief psychotic disorder. Brief matlab kya rehta hai? Chota, for some time. It's just been a month, so that is a brief period, right? So I will call that as brief. And who has named this brief psychotic disorder, guys? It was your DSM-5. So what will I call it in ICD-11? In ICD-11, I will call that as an acute transient psychotic disorder. Acute, why? Because it has just been a month. Transient, why? Because it is slowly taking place, right? And psychotic disorder, of course, because this patient has come with psychotic symptoms. Okay, I hope you guys have understood this. Less than 1 month हुआ, ICD-11 क्या बोलेगा? ICD-11 will tell me this is an acute transient psychotic disorder. What is my DSM-5 going to call it? They're going to call it as a brief psychotic disorder. Okay guys, remember this is a PYQ. Patient presenting with psychotic symptoms, okay, for less than 1 month. What is my diagnosis, guys? It is going to be psychotic disorder. Brief psychotic disorder. Okay. Next guys, now this is the differentiating point, okay? The differentiating point over here, guys, is going to be that if there is a patient, okay, who has come with more than 1 month of duration, ICD-11 says, guys, that if there is a patient with more than 1 month of duration plus showing psychotic symptoms, I will directly call this as schizophrenia. What will I call this as? I will call this as schizophrenia. This is according to ICD-11. But what DSM-5 says, guys, if I want to diagnose schizophrenia, the patient should persist with symptoms for more than 6 months. If patient persists with psychotic symptoms for more than 6 months, I will then call that as a schizophrenia. This is according to DSM-5. Okay, now you will say, okay fine, if DSM-5 is saying more than 6 months is schizophrenia, then what about the duration between that 1 to 6 months? Guys, DSM-5 says that if there is a patient who is giving me psychotic symptoms for more than 1 month and less than from 1 to 6 months, pakad lo, okay? What is the range? From 1 to 6 months. I will call that as a schizophrenia form. What will I call this, guys? What will I diagnose this as? I will diagnose this as a schizophrenia form. Okay, this is, guys, according to DSM-5. Remember, ICD-11 बहुत simple है. More than 1 month psychotic symptoms, schizophrenia. DSM-5 has subdivided it. Okay, if the range is between 1 to 6 months, guys, very very important. This is a PYQ. Okay, schizophrenia form. Whereas more than 6 months of duration of psychotic symptoms, guys, I will call that as a schizophrenia. Okay, I hope you guys have understood this much. Let us move on now. So this is your whole chart. Okay guys, remember my notes are in that way that you just have to look at it once. I'm so sorry. Okay, you guys just have to look at it once and then you will feel it will be an easy revision for you guys. Okay, I hope you guys have understood this. Next, guys, let us have a further better discussion about this one, schizophrenia. Okay. Now, guys, first let us see this model that Emily Karplin gave us. Okay. Emily Karplin, guys, he differentiated psychotic patients on two bases. Okay. He said that if there is a psychotic patient who's having episodic symptoms, okay, that his symptoms are on and off, it keeps coming and it keeps going, it is episodic in nature, that patient will come with good prognosis. Whereas, guys, you know something that is continuing for a very very long time, will it have a good or bad prognosis? Very good. By common sense, I will know that it is going to give me bad prognosis. Okay, so this is what Emily Karplin said, that psychotic patients giving me psychotic symptoms in an episodic manner will have good prognosis. Okay, and who are those patients, guys? Those patients are going to be manic depressive psychosis mood disorders. Okay, these patients are going to have manic depressive psychosis mood disorder. In today's world, we call that as our bipolar disorder. Okay, and so bipolar disorder, guys, will give me good prognosis, whereas continuous will give me bad prognosis. And what did Emily Karplin name that as? He called it as a cognitive decline. Okay, a cognitive decline. He also called this as a dementia paracox. Now, guys, we already know dementia kisme hota hai. It happens in an older age group people, right? And what does this paracox means? Paracox, guys, this is a Latin word. Okay, what means too early? So we already know that dementia happens in elderly individuals, but if there is a younger individual coming with dementia at an earlier onset, we will call that as a dementia paracox. Okay, paracox. Okay. In today's world, what do we call that as? We call that as schizophrenia. Okay, I hope you guys have understood this much about Emily Karplin, the good and the bad prognosis. Episodic matlab good hota hai. Episodic mein who comes with episodic symptoms, that is going to be our bipolar patients, whereas who will come with continuous symptoms, guys, that is going to be schizophrenic patients. Okay. Next, guys, let us understand a little bit more about schizophrenia. Who coined the term schizophrenia? Very important, guys. It was a Eugen Bleuler. Okay, Eugen Bleuler was the guy who named schizophrenia. Now, guys, another very important PYQ is that what are the 4 A's that Eugen gave? Okay, the 4 A's, guys, are going to be autism, ambivalence, affective flattening, and association loss. Okay, guys, what are the 4 A's? Autism, ambivalence, affective flattening, or we call that as a blunting, and association loss. Okay, now let us understand this better. Guys, we already know that autism, basically autistic patients, they're mostly socially withdrawn, right? They would prefer to be alone in a room. They would prefer to sit alone and mind their own business. They're not socially okay to be around. They feel anxious when they're around people, right? So social withdrawal is basically autism. Okay, next, guys, ambivalence. Ambivalence, basically, guys, these patients are unable to decide. They're confused most of the time. They're unable to decide that what they want, what is their, well, they're mostly confused, right? So that is what we mean by ambivalence. Affective flattening or blunting, guys, these patients will mostly they will not have much emotions, if you will say, in a way. For an example, if I have schizophrenia and I am showing affective flattening, all of a sudden my neetpg rank is going to be rank number 1. Okay, I'll be like, okay, supposedly I failed my neetpg, God forbid, and it shouldn't happen, but if it happens, okay, I'll be like, okay, no problem. Meaning, even a good thing is happening to me, I'm not showing any emotions. A bad thing is happening to me, I'm not showing any emotions. There is a flattening of my mood. There is blunting. There is flattening. There is blunting of my mood. Okay, that is what we mean by affective flattening or blunting. I hope you guys have understood this. Next, guys, loss of association. We already spoke about this. Well, it happens in schizophrenic patient, formal thought disorder, right? I hope you guys remember. So that is what we mean by association loss. Now, what is the question that comes from here, guys? Now, we already know what is a 4A. Okay, and we know that in schizophrenic patients, auditory hallucination is a very very common psychotic symptom. This is where they'll confuse you, guys. They will tell you, according to Eugen, which of the following is not, okay, which of the following is not one of the 4 A's that Eugen Bleuler gave with regards to schizophrenia. Now, a person who is very confident, oh, auditory hallucination to aata hai, schizophrenia ka symptom hai wo. This is where they confuse you guys. Remember, what is not in the 4 is, can anyone see over here auditory hallucination? No. So remember, auditory hallucination is not one of the 4 A's. Okay, auditory hallucination is not one of the 4 A's. How am I going to remember? AHRR. So remember AH guys, it's everywhere else it is a single A. Autism, ambivalence, affective flattening, association, है ना? Remember, auditory hallucination is not one of the 4 A's. Okay, and what is the other A guys that they given the PYQ? This is where I wrote. Okay, this is an important PYQ. Okay guys, auditory hallucination is not in the 4 A's. The other A that they confuse us is with automatism. Automatism guys, basically you must have noticed that there are certain patients who have lip smacking, like who will keep lip smacking, right? Or more very common in temporal lobe epilepsy patients. Okay, but temporal lobe or epilepsy patients. Okay, so automatism is also not one of the 4 A's that Eugen gave. Okay, so I hope you guys have understood this. Everything is there in the notes guys. Main thing is that you need to understand and just find out where I've written what. Okay, Baki, I have written down everything over here, that so that it's easy for you guys to understand. Okay, next guys, now we have already discussed the various psychotic symptoms. Okay, now guys, let us go in a little depth and talk about the first rank symptoms. Okay, one thing that you guys need to know, that there are going to be 11. Okay, 11 first rank symptoms. Okay, and how am I going to remember it? What is the first number? That is your first, है ना, 1. So 11 symptoms are going to be there. Okay, and who gave me these first rank symptoms guys? This was your Kurt Schneider. Kurt Schneider was a dude who gave us our first rank symptoms. Okay, now what are the different 11 different symptoms? There are going to be 3 auditory hallucinations, 3 made phenomena, 3 thought phenomena, 1 somatic passivity, and 1 primary delusional experience. Okay, 3 auditory, 3 made phenomena, 3 thought plans, and somatic and primary delusional experience. Now guys, let us understand this in a little bit more depth. Okay, let us now talk about the about the 3 auditory hallucinations. Okay, so under 3 auditory hallucination, it is subdivided into first person auditory hallucination, second person auditory hallucination, and third person auditory hallucination. Okay, what do we mean by first person auditory hallucination? Okay, so these are the subtypes of auditory hallucination that we're going to discuss. Under first person auditory hallucination guys, what you need to understand is that supposedly I'm having a thought in my mind that okay, tonight I'm going to eat biryani. Okay, this thought of mine, I can hear it. Okay, like whatever you think, you hear it. Okay, like meaning I'm thinking right now, okay, today I'm not going to go to my hospital. I can hear it. Today I'm not going to go to my hospital, right? So whatever I think, I can hear it. So that is what I mean by first person auditory hallucination. We also call this as a thought echo. Why thought echo? Because whatever I'm hearing, I can hear it. We will also call this as a sonorization. Why? Because my thoughts are having a sound. Okay, because my thoughts are having a sound. Okay, so our first person auditory hallucination is also called as thought echo or sonorization. Okay, this is our first person auditory hallucination. I hope you guys have understood it. Whatever I hear, I can whatever I think, I can hear it. That is what I mean by this. Next guys is your second person auditory hallucination. What do I mean by this is guys, that there is a voice that is directly talking to me. There is no thought in my head, but there is a voice that is coming and telling me. Okay, there are 2 types. Okay, there is one commanding and there is one commentary. Okay, commentary as in like whatever you're doing, that there is someone commenting about it. Okay, now Simran is walking, friend. Okay, now Simran is writing down. Okay, now Simran is going to sit and she's writing down something. Simran is teaching right now. There is someone who's commenting, who's giving a commentary of everything that you're doing. Can you even imagine how annoying that is, right? Another, this is a very, very dangerous one, that is commanding voice guys. They will tell you what to do. Okay, that they will tell Simran, go commit suicide. Simran, go jump. A commanding voice. Okay, can you imagine how dangerous that is? Okay, so that is why guys, you must have seen that there are patients who come to the hospital, okay, with attempt to suicide. On asking them why did you do it, they'll tell there was a voice that told me to do it. Okay, so this is your second person auditory hallucination, where there is a voice that is directly talking to you, telling you what to do. Telling you what to do is the commanding type. commenting on everything that you do is your commentary type. Okay, I hope you guys have understood second person auditory hallucination. Whereas what is a third person auditory hallucination, guys? Over here, there are voices who are talking to each other, not to you. There are voices who are talking to each other. Okay, they're not talking to you, and I as a patient can hear everything, meaning there are multiple voices in my head, right? You must have heard that. Multiple voices in my head talking to each other. Okay, not to me directly, but talking to each other, which I can hear. Okay, so I hope you guys have understood. In first person, I am having a thought, I can hear it. Okay, second person, there is a voice directly talking to me. Third person, there are two voices talking to each other, which I can hear. Okay, so I hope you guys have understood the three types of person auditory hallucination. Okay, next, guys, the three made phenomena. I hope you guys are understanding this so far, right? Now let us talk about the three made phenomena. In three made phenomena, guys, we have impulse, we have violation, and we have effect. Impulse, guys, impulse is something that I'm very impulsive. Like, people say you're very impulsive, like, you know, when you're solving, like, you have just, like, this happens to us a lot during exams. Okay, we see a question, like, oh yeah, we know what the answer is. Impulsively I will tick on it and I'll come. Later on पता चला नीचे I accept लिखा है. Okay, which of the following is written there, which I very gladly I skipped it and I came. Okay, and my question went wrong over there, right? So guys, remember, this is one thing that you guys should not do. Don't be impulsive. Okay, read the question carefully and then answer everything. Okay, so be very, very careful with that. Okay, that don't be impulsive with your answers. Okay, just a minute, guys. Okay, so this is impulse. Impulsive basically means brief act. Like, I have thought about something, I'm going to act upon it. Okay, that is what I mean by impulse. Okay, done. Okay, and what will they say? That it made me do it. Okay, like, it is done by them and someone made her do it. Very briefly, like, kar. That is what I mean by impulsive. Violation, guys, this is a complex act. Okay, meaning I know that, like, supposedly I'm very, very angry right now. I'm very angry right now. Okay, and I want to take it out to throw my phone. Okay, but then I'll think, okay, nahi yaar, but let me just remove my cover. Okay, let me remove the all the important things, whatever it is. Let me first remove my screen guard. Like, I'm taking time to throw my phone away. Okay, I'm thinking it through. I'm like, will I get a new phone later on or not, right? So that is what I mean by violation. Violation is basically, it is a complex act and it is a planned behavior. Whatever I'm going to do, I'm going to plan it out. Okay, fine, let me remove my cover, let me remove whatever chip, whatever shit is there in the phone, right? So that is what we mean by violation. Okay, I hope. And the third one is going to be our effect. Okay, I hope you guys have understood this much. Next, guys, let us talk about the three thought phenomena. I hope you guys remember that when we were talking earlier about thought phenomena, we spoke about insertion, withdrawal, and broadcast. In insertion, we saw that there were thoughts that are getting inserted. Withdrawal and broadcast is basically that whatever I'm thinking, everyone can hear it. Okay, if you want a brief, a much better detailed version of this, you can go and watch the previous videos. Okay. Next, guys, somatic passivity. What do I mean by somatic? Somatic means body, and passivity is, guys, basically it is a delusion of control. What do I mean by that, guys? That there is a role of an external agency. Someone else is controlling you. Okay, that someone is controlling my body. Someone is forcing me to do it. किसी ने मेरा हाथ पकड़ के बोला ये कर. Okay, that is what I mean by somatic passivity. Body and passivity, basically, like, it is a delusion of control. Okay, that is what we mean by somatic passivity. Also, we call this as a delusion of control. Okay, with someone, there is an external agent or there is an external person who's telling you what to do. Okay, that is what we mean by somatic passivity. Next, guys, is our primary delusional experience. Okay, primary delusional experience. Under primary delusional experience, guys, we have 4 delusions. One is delusion of idea, second is delusion of memory, third is delusion of mood, and fourth is delusion of perception. Now let us give a little better understanding about this. Okay, delusion of idea, guys, is that this patient will stick to the idea that he or she has. That there's a patient who will just stick to whatever idea that he or she has, as in, if something is wrong with me, something is wrong with me. No matter how much I explain, I'll be like, you're fine, nothing's wrong with you. Then you'll be like, नहीं, but something is wrong with me, something is wrong with this doctor that she doesn't know what is wrong with me, right? Delusion of memory, that guys, that's something that has happened, that has not happened, but then I believe it has happened. That, for example, I've seen a dream or someone, this random person who's come to kill me, I will believe that this person has come to kill me, even though it has not happened. I will have my imaginary memory ki nahi, this person came and killed me. Okay, that is what we mean by delusion of memory. Delusion of mood, okay, that this patient is always mostly going to be like, you know, he's going to be in a certain mode most of the time, right? And delusion of perception, that this patient is going to have a reasoning, he's going to find a reason for everything. Okay, a random reason that will not make sense, but he will have a reasoning. Okay, that is what we mean by delusion of perception. I hope you guys have understood the 4 primary delusional experiences. Okay. Okay, so now guys, everything that we discussed earlier from the first rank symptoms, guys, these are the positive symptoms of psychotic patient. Now you will think, what are the negative symptoms of the patients, right? Negative symptoms, guys, are mostly going to consist of A's. Okay, they're going to start with the letter A. Okay, so what do I mean by what are the different negative symptoms? Let us look into it. Okay, first is going to be apathy. What do I mean by apathy, guys? Very important PYQ. Apathy is a lack of interest in the surrounding. उसको किसी चीज से लेना देना नहीं है. Okay, he is not interested in anything. That is what we mean by lack of interest in surrounding. Apathy. ठीक है. Whereas avolition, that is basically the unwillingness of doing something persistently. Like, you know, most of us, we have this drive, yeah, FMG nikalna hai, whatever happens, I have to clear my FMG, right? There's a drive forcing us to do it. This patient after a while will be like, screw it, meko nahi karna, I'm not interested in this, right? This patient is unwillingly to do something for a longer time. He has lost the drive to do something. Okay, this patient cannot be persistent with anything. That is what we mean by evolution. Okay, another very important, guys, this is a PYQ as well, anhedonia. Okay, anhedonia, guys, is the loss of pleasure from a previously pleasurable activity. For an example, guys, if I loved gardening earlier, now I'm just like, I'm not interested in gardening. If I love to roam around earlier, now I'll be like, I don't want to go anywhere, I just want to be home. Okay, so I have lost the pleasure that I used to get from gardening, from roaming around, right? But now I'm just not interested in any of it. That is what I mean by anhedonia. And this is a very important symptom, guys, of depression. Remember, depressive patients, they have lost interest from things that they were earlier interested in. What gave them pleasure, what gave them happiness earlier, these patients are not interested to do any of those activities anymore. Okay, very important, guys. Remember, this is a PYQ. Okay, next, guys, attention deficit. This patient is not going to be very attentive to things like as he or she was earlier. That is what we mean by attention deficit. Next, affective flattening. Again, guys, we have already mentioned this is flattening. We have already mentioned this earlier, guys. Affective flattening is a very important symptom of schizophrenia. We also call this as a formal thought disorder. Okay, next, alogia. Alogia, guys, is basically poverty of thinking or speech. Okay, that this patient, if you will ask him or her anything, he or she will only and only answer in a monosyllable or a bisyllable answer. Okay, like for example, are you interested in something? Yes. Do you want to go out? No. Okay, like he or she is not going to explain that why she does not want to go out, why she's interested in something. No. Yes, no. Do you want to continue this conversation? Are you feeling better about this conversation? Okay, so that is how this patient is going to answer. Okay, this is alogia. Okay, I hope you guys have understood this. Now, guys, this is basic common sense that more the negative symptoms, more my patient will come with any of these or most of these symptoms, my patient is going to have a bad prognosis. Okay, more the negative symptoms, worse the prognosis. Okay, because they are negative symptoms, naam mein hi likha hai, there is something negative about this. The more it happens, the more worse the prognosis becomes. Okay, now, guys, we have these good and bad prognostic factors. Okay, we have a good prognostic factor and a bad prognostic factor. Okay, good is over here and bad is on your is on my right. Okay. Now under good, guys, what are the different various good prognostic factors? I have placed them like one side or the other. Why? Because you guys can compare, because this is also a PYQ, guys. They will ask you what are the various good prognostic factors, what are the various bad prognostic factors. Okay. So now, being a female is a good prognostic factor, so good for us. Okay. So being a female is a good prognostic factor. Later onset, the later it has started, is a good prognosis factor, right? Acute onset, that if it has happened for a brief amount of time, that is also good prognosis. Okay. Onset, which has followed, which was due to a stressful life event, meaning this patient who had a really majorly stressful environment. Like for an example, if there's a patient who lost someone very very close to herself, okay, that person has passed away, so that is a stressful life event, right? If it is after that, that is also good prognostic factor, hai na? If this patient will come with positive symptoms, what were the positive symptoms we discussed, guys? Those were your first rank symptoms. Okay, any of those, it is a good prognostic factors. If this patient will have effective symptoms, if this patient will have more symptoms, it is a good prognostic factor. If this patient, very important, guys, is compliant with your medication, which is very very important, guys, that if we have given a certain medication to our patient, this patient should be compliant with those symptoms, right? That is also a good prognostic factor. Okay. Next, if this patient and yeah, also remember, guys, is compliant with medication and he or she has no side effects. Okay. Next, guys, if this patient has support from family, guys, remember, patients who have a certain mental illness, their family support will mean the most to this patient. This patient often feels alone, often feels neglected, often feels like no one understands him or her. Remember, guys, if you have anyone who is going through a certain phase of their life, it will not cost you much than a minute or two to sit and be there with this person, listen out to what he or she is going through, and help this person, right? So remember, support by family, friends, or whoever. Okay. And very important, guys, has no family history. Okay. No family history is also a very good prognostic factor. Okay. So these all are good prognostic factors. Now let us look at the bad prognostic factors. Okay. So now we know females are good prognostic factors. What are males? Males will have bad prognosis. Okay. Next, premorbid personality issues. This patient has had a later onset. Also, this patient has had a later onset is basically, it is a good prognostic factor. Okay. Remember, guys, this is my bad. Okay. This patient has had a patient is having chronic psychotic symptoms, and which is very insidious in onset. Okay. Patients with negative symptoms, every A, right? I hope you guys remember the A's that we just recently discussed. Okay. That is your negative symptoms. Okay. Patients who are aggressive, okay, they're very aggressive. Okay. And they are patients who have had multiple admissions, right? Who have had a history of certain addictions. These all are bad prognosis, guys. This is a patient who has had multiple admission, in and out, whatever it is addicted to a certain substance, right? Or who are very very aggressive. All these are bad prognostic factors. Okay. If this patient has had a perinatal insult, also is a bad prognostic factors. If this patient has any neurocognitive defects, and very important, guys, is a family history of schizophrenia, will push this patient towards a bad prognosis. Okay. So these are the various prognostic factors that we have discussed. I hope you guys have understood this, and I'll see you guys in the next video. If you guys have any doubt, let me know. Thank you so much.